Let us start with the recitation of Kitab Al-Fatiha. Dear all participants, please fill in the Google form for the start point via the link provided. Without further ado, I would like to invite our speaker for today, Dr. Faris, to start the session. Please welcome.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Boleh nampak slide ke? Saya boleh dengar suara saya? Okay. Alright, so today our topic is obstetric emergency. Tapi first of all, sebelum saya present, saya nak clearkan, bagi disclaimer sikit lah. So for this topic, this is basically just a sharing session. Dia bukan lecture. Anything you want to ask, you can ask later. Cuma for every seminar, we should have our aim lah. So aim saya untuk obstetric emergency ni, I just want to outline certain, jangan saya nervous lah. So I just want to outline certain topics yang I think can help you in your clinical setting especially. So this lecture merely will focus more on clinical rather than theoretical lah. I try to make a case discussion, tapi I think for case discussion for this topic, it would not be as concise as presentation will be lah. Tapi for year 5, you will have your own seminar of obstetric emergency dengan Dr. Fahmida later. So let's say because I left obstetric since March last year, so dah setahun lah tinggal obstetric ni. Cuma revise waktu pro hari tu je. Cuma kalau ada apa-apa yang salah tu nanti just bagi tahulah kalau ada apa-apa yang nak tegur ke, yang mana-mana year 5 yang masih fresh lagi kan. Okay, so now kita start Right, so obstetric emergency, you have set few topics lah. So among them are preeclampsia, uterine inversion, AFE, cord prolapse, shoulder dystocia, and postpartum hemorrhage. So to cover the whole topic in this session, I think it's impossible because you will need 2 hours to cover everything. So I think I'll just focus on the things that will be frequently encountered in your clinical setting, which is shoulder dystocia and PPH. Okay, disclaimer lagi. So kalau macam shoulder dystocia ni, sorry, I'll mix English and BM. Shoulder dystocia ni, sometimes you will, if you have clinical teaching kan, sometimes you will see like in labor room, patient ended up with shoulder dystocia. But in postpartum hemorrhage, I've never seen once in my clinical setting. Tapi dia banyak keluar dekat teori lah, teori PMP, banyak keluar tentang postpartum hemorrhage. Okay, the other things macam preeclampsia tu very common. So definitely if you got preeclampsia case in your modified long case, especially 3rd year, 5th year kan, so you will definitely ask about the obstetric emergency management of eclampsia. Sama juga macam shoulder dystocia. Let's say you have a patient with GDM. So one of the complication is macrosomia. So patient will end up with shoulder dystocia. So the common questions about shoulder dystocia is what is shoulder dystocia and how do you manage shoulder dystocia. So at the 3rd year level, you should be familiar lah dengan management of shoulder dystocia. At least you can name a few of maneuver that you can use in order to cater shoulder dystocia ni. Okay, now. Okay, so by definition, what is shoulder dystocia? Shoulder dystocia is a vaginal catheter delivery that requires additional offset. Okay, now it's moving. Okay, kalau saya buat ni, moving tak? Okay, so kena buat macam ni lah ni. Kalau buat macam ni, you all nampak tak? Mana? Reading view ni. This one? Nampak? Okay. Alright, so shoulder dystocia. Okay, ni yang I cakap tadi lah, outline tadi kalau you all tak nampak tadi. So shoulder dystocia is a vaginal catheter delivery. So the prerequisite, it should be a vaginal catheter delivery. So kalau cesarean section, tak boleh lah kita kata sebagai shoulder dystocia. Okay, so it requires additional obstetric maneuver to deliver the fetus after the head has been delivered and after genital traction phase. So in this definition, there are few key points. Number one, it should be a vaginal catheter delivery. Dia tak ada nak buat pointer lah. Nampak cursor tak? Ni kan? Vaginal catheter, nampak cursor lah? Okay, so just tengok cursor lah. Vaginal catheter delivery, it should requires additional obstetric maneuver and it should be happening after the fetal head has been delivered and after genital traction phase. So ada 4 key points lah, key points in the definition. So it can occurs whether the anterior ataupun the posterior fetal shoulder is impacted on the maternal symphysis or sacral promontory. So kalau you tengok anatomy kan, belah atas tu, just imagine the mother is currently in lithotomy position and you are the attending physician, so you akan ada dekat bawah kan, dekat celah kaki mother tu. So at the above is the maternal pubis, maternal symphysis pubis, and below is the sacral promontory. So it can be either the anterior shoulder impacted at the maternal symphysis pubis or the posterior fetal shoulder impacted at the sacral promontory, either one. So kalau it satisfies one, we can say that this is shoulder dystocia. So the incidence according to RCOG guideline ni yang I quoted ni, actually it about 0.58% to 0.7%. So roughly 0.6% lah. So I just make it roughly lah. Okay, now in order for you to understand about shoulder dystocia, there are few prerequisite knowledge that you should have. Number one is the stages of labor. So stages of labor, as you know, you have 3 stages of labor kan. First stage from 1 cm until 10 cm. So you have latent phase of labor, latent phase of labor, and also active phase of labor. So latent and active phase of labor ni both are in the first stage. Second stage is from 10 cm until delivery of the fetus, and then third stage is from delivery of the fetus until the delivery of the placenta. So shoulder dystocia only happen in the second stage of labor. So maksudnya daripada 10 cm until the delivery of the fetus. Okay, and then you should also know about the mechanisms of labor lah. So mechanisms of labor, normally they would not ask you in the theory, but you might be asked in the clinical teaching, in the clinical setting lah. So first, so you have 8 stages, 8 mechanisms of labor lah. 8 mechanisms of labor. Number one is engagement, descent, flexion, internal rotation, extension, restitution, external rotation, and body passage. So restitution in external rotation is the phase where the shoulder dystocia will happen. And then lastly, you should also know about the factors that affect labor. So some books say, some teachers say 3 piece, another books can say 4 piece. They include psychological factor as one of the factors that affect labor. So with regards to shoulder dystocia, we are mainly speaking about the passage and also the passenger. So for example, if patient with CPD, let's say kalau saya pakai apa tu, short form kan. So kalau ada third year yang tak faham ke, second year tak faham, boleh tanya. So kalau mothers ada CPD kan, cephalopelvic disproportion, so maksudnya dia ada narrow pelvis. So narrow pelvis is the one that has risk factors to have shoulder dystocia. And then passenger is the fetus. So passenger yang besar lah, microsomic baby, GDM mother, so they have a risk of shoulder dystocia juga. Okay, now looking at this picture, so these are 2 comparisons of normal delivery and shoulder dystocia. This is very basic lah. So you tengok dekat first picture tu, you tengok the anterior shoulder can be passed through the maternal symphysis pubis, whereas if you see the arrow there, in shoulder dystocia, the maternal symphysis pubis, the anterior shoulder is impacted at the maternal symphysis pubis, so the body cannot pass through. So this is basically the normal one and the shoulder dystocia, just to give an idea for those yang mungkin tak clear lagi. Okay, so there are a few risk factors. If you read Kitan teachers, they only mention about the antepartum risk factors. They didn't mention about the intrapartum risk factors. But some journals, they also outline the intrapartum risk factors. So we go one by one lah. So macam antepartum risk factors, mother who have a previous history of shoulder dystocia, so they have a risk to have another shoulder dystocia in the subsequent pregnancy. So about 1 to 25% risk. And then patient who have a macrosomic baby, especially with mother with GDM, as I mentioned, they also has a very high risk of getting shoulder dystocia. And then DM. DM ni you kena hati-hati. DM ni is a trap question. So between kalau ada yang tak tahu lah. So DM saya sentuh sikit. DM we have a pre-existing diabetes mellitus and also gestational diabetes mellitus. Gestational diabetes mellitus is mother who are diabetic being diagnosed once she is pregnant, while pre-existing diabetes mellitus is mother who are already diabetic since the very beginning and then she gets pregnant. So this is the differentiation. So between GDM and pre-existing diabetes mellitus, the one that are high likely to get a big baby is the one who have gestational diabetes mellitus. For those who have pre-existing diabetes mellitus, if they weigh the risk between macrosomic baby ataupun lower gestational age, maksudnya baby yang kecil lah, sama ada kalau kita differentiate SGA and LGA. So mother who have pre-existing diabetes, they are prone to get SGA rather than LGA. SGA tu small for gestational age lah. Okay. Kalau ada yang tak clear nanti boleh tanya balik. So the point here is that GDM is the one that has a risk factors for macrosomic baby. And then maternal BMI, obese 30 kg per meter square above, and then post date and short stature. So short stature ni is the one that correlate with CPD tadi lah. CPD. So short stature dia punya definition, kalau you tengok definition untuk CPD, mother who are less than 145 cm. Maksudnya siapa-siapa yang bawah 145 cm tu, they are prone to get cephalopelvic disproportion. Okay. Now, intrapartum risk factors, number one is a prolonged first stage of labor, prolonged second stage of labor, secondary arrest, and oxytocin augmentation. So you should know prolonged first stage, prolonged second stage, secondary arrest. This one is completely another topic. Masa OSCE kita orang itu masuk secondary arrest, dia bagi patogram. Betul lah, patogram, dia bagi patogram, and then dia suruh you interpret based on the patogram and give the diagnosis. So at that moment I got the answer wrong lah. I thought it was a prolonged second stage. So actually it was a secondary arrest. Telling you this because this is actually what you will see in your exam. So it's very important lah. Nanti baca mechanism of labor dan yang saya cakap ni, first stage, second stage and third stage ni. Okay, now with regards to shoulder dystocia, in history and PE, I just try to correlate a bit with the clinical setting. So let's say you got a long case kan. So kalau you got long case, you takkan dapat lah case shoulder dystocia at that moment because our topic today is obstetric emergency. So definitely emergency would not be in your exam. Definitely emergency is life-threatening. So dia takkan ada dalam exam you ada semua stable patient. So the way they will ask you is that let's say you get a GDM in pregnancy. So you need to correlate with your history lah. Let's say you know patient is GDM. So first thing, isi bawah yang bawah ni. So yang first you kena tanya dia about fetal parameter, dia punya head circumference. Kalau mother tahulah head circumference, correlate tak dengan dia punya LMP tu. So tanya juga kalau macam ada any evidence any evidence of macrosomic baby from ultrasound. So maksudnya fetal parameter ni lah during serious scanning. So kalau patient tu mati parah pula kan, you ask about previous history of shoulder dystocia in previous pregnancy. Sebab yang kita cakap tadi, yang this one ni kan, so previous shoulder dystocia is about 1 to 25% risk in the subsequent pregnancy. So you ask about this, and then from the physical examination, you try to elicit the risk of difficult labor based on the risk factors that I've mentioned. Number one, you see head to toe, you rasa mother ni short stature ke tak? Kalau short stature, you can tell the doctor. So from my examination, this mother short stature, so dia ada risk untuk dapat shoulder dystocia. And then obesity, you also screen for obesity. Of course, in your exam, you would not have the luxury to see the weight and the height and the BMI of the patient. But from gross eyeballing, you can say that this patient probably might be obese. But certain lecturers, macam Dr. Azhar, dia tak suka you cakap patient obese in front of the patient. So probably you kena pandai lah bagi ayat macam tu. Tapi lecturer lain macam kalau you cakap ni, dia akan puji lah, maksudnya you are outlining the risk factors. Okay, and then you see the evidence from the physical examinations, you see the evidence of large for gestational age. So you kena tahu lah definition of LGA. And LGA, kalau ikut buku Prof Bayah tu, siapa-siapa yang ada boleh tengok buku Prof Bayah, dia kata 3 cm and above is considered as LGA lah, large for gestational age. Discrepancy between current LMP pula, current apa tu orang kata, ialah beberapa minggu sekarang dengan dia punya symphysis final height dengan clinical final height to more than 3 weeks. So that one is considered as LGA. So from the history and PE, what I'm trying to say is here, I'm trying to summarize again kalau you lost in the in between. So what I'm trying to say here, from history and PE, you should be outlining the risk factors about shoulder dystocia. So kalau ada risk factors tu, and you can mention it quite a few to the lecturers, so they will be very happy. But mind you, once you mention about this, then subsequent questions will be about shoulder dystocia. So make sure you have enough knowledge lah kalau you nak mention everything. Right, so now pertaining to the history taking and PE, that's basically it. So now the diagnosis, how you want to diagnose this patient have a shoulder dystocia. Okay, so first of all, you see that there is a difficulty with the delivery of the face and the chin. Okay, and then the head is remain tightly applied to valve or even retracted, theta sign. Now, the next question is, what is theta sign? So theta sign is a clinical science where there is a retractions of the head of the fetus, gambar ni, hujung sini, retractions of the head of the fetus against the perineum of the mother. Okay, so that is the theta sign. If you would like to define, you should know how to define lah. Okay, and then so as I mentioned before, it correlates with the mechanism of labor. So in shoulder dystocia, basically it's because of the failure of restitutions of the fetal head and the failure of the shoulder to descend because of the shoulder is impacted at the sacral promontory ataupun at the maternal symphysis pubis. Okay, that's basically how you do diagnose. It's totally a clinical diagnosis. You don't need any investigation to diagnose shoulder dystocia. Now, moving on to the management part. So management part ni, kalau saya tak silap masa saya tak year tu, doktor tak ada lah macam, waktu tu Dr. Fahmida tak ada. So dia Dr. Darin macam dia tak ada expect tinggi sangat about the management. As long as you tahu buat Matt Robert maneuver dengan external pressure, they are happy enough. Tapi masa fifth year, I need to remember everything about the management lah. Nevertheless, we go through one by one. So first of all, management ni, you can divide your management if you are being asked about how do you manage shoulder dystocia. So you can divide your answer into I would like to divide my management into a general measures first, and the definitive management if patient got shoulder dystocia. So the general measures is, number one, you need to identify all the risk factors that I have mentioned from the history, from the physical examination, from the ultrasound. So if there is any risk of patient getting shoulder dystocia, so you need to anticipate senior medical officer, obstetrician to be standby. You need to have your pediatrician to be standby. You need to have your OT to be standby, and this would benefit enough to the patient if betul yang dia memang ada shoulder dystocia at the later moment during the delivery. Okay, so that one is general measures if patient have a risk of getting shoulder dystocia. And then the definitive management, if patient ended up with a shoulder dystocia, you can give the answer based on the mnemonics of helper here. Okay, helper here. Okay, so first of you call for help. Okay, call for help ni kalau you pernah tengok shoulder dystocia, siapa pernah tengok shoulder dystocia, dia bukan macam tolong, tak macam tu lah. Dia akan menjerit sekuat hati dalam labor room tu kan. Shoulder dystocia dia menjerit macam tu lah. So maksudnya this is a very serious condition. Kita orang yang ada dalam tu macam, oh ini pahal kan, cuak kan, macam tu lah. So first thing first is call for help. You need to have assistant, at least you, the attending physician, and there are two other assistants to be with you at least at the moment. Okay, and then E is evaluate for episiotomy, and kita akan go one by one lah nanti. Legs saya tunjuk gambar apa semua. Legs, P is pressure, E is enter maneuver, R is remove the posterior arm, and another R is roll the patient to hands and knees. And not to forget, so once you get shoulder dystocia, make sure you empty the bladder, catheterize and empty the bladder. Sebab one of the causes of shoulder dystocia disebabkan oleh full bladder juga. Okay, tu tadi saya terlupa. Okay, now help. So when I've mentioned about helps, you need to get the help from the nurses, at least two nurses helping you, and then you need to inform the senior MO, obstetricians, and also pediatrician. Okay, so you cannot ask them. You cannot put a fundal pressure. They will put a fundal pressure. You will just injure logic, and lepas tu you discourage maternal pushing. So you suruh dia pushing against resistance. So anak dia lah yang akan dapat injury and brachial plexus injury, etc. For episiotomy. So you shouldn't read this side. This side is meant to be read later. So what I want to mention is that the episiotomy is actually not necessary. I mean, it is not for giving a space for the fetus to go through, but rather is actually a way to give a roomy space for the attending obstetrician to insert their hands later on. So tadi macam tadi kita ada enter maneuver kan. So enter maneuver tu, so the usage of episiotomy is we want to give a bit roomy space for the attending obstetrician to enter their hands inside. So itulah role of episiotomy in the case of shoulder dystocia. Okay. Now legs. Okay, legs. Okay, ni pun nanti baca. Okay, legs. Okay, now legs maneuver. So legs maneuver ni ada satu je, McRobert maneuver. McRobert maneuver ni cara dia, you hyperflex the hip and also the knee. So there will be kalau kat HTA biasanya dia akan ada satu nurse kat belah kanan, satu nurse kat belah kiri. They will help the patient to hyperflex the hip and also the knee, and then they abduct the hip. The idea is because they want to increase the diameter of the pelvic outlet, yang ni gambar D. So dia nak increase the diameter of the pelvic outlet supaya it is more vertical. So it gives a more roomy space for the fetus to be delivered. That's it. And normally it is combined with another maneuver which is suprapubic pressure. So maksudnya dia buat McRobert maneuver tu, at the same time the nurses will apply the suprapubic pressure on top of the maternal symphysis pubis, so that it allows the passage, and the mother at the moment should push the baby out. Okay, so normally about 70% of cases of shoulder dystocia, they will respond by McRobert maneuver and suprapubic pressure. Ini dia. Okay, ni yang saya cakap tadi lah. Alright. Okay, so when you applying the pressure, you are actually applying the pressure on top of the anterior shoulder of the fetus. So the idea is when you apply pressure, the shoulder will be adducted. Maksudnya dia akan kecil ke dada. So dia akan the shoulder will be directed towards the chest. So the anterior to posterior shoulder diameter will be lessened and it can pass through. Okay. Now, so kita dah belajar tadi yang first call for helps, and then you buat helps, lepas tu E tadi apa? Episiotomy. Okay, episiotomy, and then McRobert maneuver, suprapubic pressure, and then the enter maneuver. Enter maneuver ni kalau dulu you cakap enter pun dia dah puas hati lah, tapi Dr. Famida kan, standard lah, Dr. Famida dia particular sikit. So you should know, I think you should know at least two of the enter maneuver. So we have normally I'll talk about Rubin's 2 maneuver and reverse wood screw maneuver, yang ni je. Rubin 2 dengan reverse wood screw. Okay, so if kalau you tengok kan, tengok gambar. Okay, tak apa, saya explain lah. Kalau Rubin's 2 maneuver ni, basically you try to trace, you enter your hands and then you try to trace the posterior aspect of the anterior shoulder. Bayangkan masukkan tangan tu, you masukkan tangan daripada kepala dia, masukkan sampai you trace the posterior aspect of the anterior shoulder and then you try to adduct the shoulder. So the idea sama juga, we want to decrease the anterior to posterior shoulder diameter. Okay, itu adalah Rubin's 2 maneuver. Reverse wood screw maneuver, yang ni lah. So you enter, tapi you enter towards the posterior shoulder rather than to the anterior shoulder, you enter posterior shoulder. Sama juga, you take the posterior aspect of the posterior shoulder and then you try to adduct the shoulder. So at that moment baru boleh pass through. Okay, so that one is Rubin's 2 and reverse wood screw. So kalau you tengok ni, gambar ni kan, daripada anterior shoulder ni anterior shoulder, belakang ni posterior shoulder. Yang ni dia punya anterior fontanel, posterior fontanel. So sekarang ni patient ni menghadap ke sini lah. Okay, so maksudnya you masukkan tangan and then you adduct at the posterior aspect of the anterior shoulder ni. So dia baru boleh the fetus to be passed through, dislodged from the impacted maternal pelvis. Okay. Okay, setuju kot. So ni yang saya masukkan tadi. Masukkan tangan, tolak daripada belakang. So this one is Rubin's 2 maneuver. Okay. This one is ni posterior shoulder tau. Ni bukan anterior shoulder, ni posterior shoulder. Reverse foot screw sama juga, you masuk tangan ke belakang patient tu, lepas tu you try to adduct, ke patient. And then you try to adduct the posterior shoulder. And then wood screw ni basically sama je. You satu tangan you masukkan dekat satu tangan at the posterior aspect of the anterior shoulder, satu tangan is at the anterior aspect of the posterior shoulder. So dia akan macam, you faham tak? Macam tu. So ni adalah wood screw. Tapi wood screw ni masa kita ada workshop obstetric emergency dulu, bila saya cakap pasal wood screw ni, MO tak faham pun. MO dia just tahu buat je, tapi dia tak tahu nama lah. Tapi you should at least know Rubin's 2 dengan reverse wood screw tadi. Bolehlah sembang sikit-sikit nanti dengan kalau cerita tanya. Okay, so ni yang saya maksudkan tadi, Rubin's 2, you ambil daripada anterior shoulder. Kalau reverse foot screw, you ambil daripada posterior aspect of posterior shoulder. Kalau Rubin 2 campur dengan wood corkscrew maneuver, yang macam ni lah. So satu ambil daripada anterior shoulder, satu tangan lagi, masukkan dua-dua tangan dulu, satu kat anterior shoulder, satu kat posterior shoulder, tolak. Okay, so ini adalah enter maneuver. Okay. Now, kalau with entering maneuver tu still not dislodged yet, still cannot be passed through. So the next maneuver is remove the posterior arm. So apa macam ni you nak buat? You insert your hand inside and then you trace down from the shoulder down towards the arms and then towards the forearm, and then when you get the wrist, you hold the wrist, grab the wrist, and then you sweep the arm across the chest and you pull it out. So kalau you nak pull it out pun you kena hati-hati sebab there is a risk of brachial plexus injury. Okay, so this is the next maneuver. Okay, and then lastly is gaskin maneuver. Gaskin ni maksudnya all four lah. You kena ask the patient to flip around and then lift the leg for running start macam ni. Okay, and then as the attending physician, we try to rotate the fetus in oblique position, and then after that, kalau tak boleh juga nak keluar, remove the posterior arm macam biasa. Okay, so gaskin maneuver ni pun the idea is because it enlarge the pelvic outlet. Okay, so settle. Okay, let's say if all these maneuvers still fail, so the next resort is Zavanelli dulu, baru ni terbalik ni. So Zavanelli dulu lah, biasanya kita buat Zavanelli ni maksudnya I've said about the mechanism of labor tadi kan. And so dia akan reverse back that mechanism of labor and then they will push back the fetal head inside the mother. So maksudnya fetal head tadi yang dah terkeluar tu, yang tak boleh nak keluar, yang tersangkut kat situ, dia akan pusingkan balik ikut mechanism of labor tu, tolak balik masuk dalam mother punya uterus. So nanti after that they will ask the OT to prepare, push the patient to OT, and then kita buat cesarean section. Okay, tapi mind you that Zavanelli ni macam mana? Zavanelli is very harmful lah basically. So obstetrician we don't encourage Zavanelli much unless if there is no other choices. Kalau kita dah buat manuver yang lain tadi 2 kali semua tak boleh, then Zavanelli is an option. Another option previously before the advancements of technology is deliberate clavicle fracture ataupun cladotomy yang atas ni. Cladotomy maksudnya you pinch the clavicle of the fetus, so it will be fractured. So, yelah fractured lah. And then bila fracture tu dia akan termasuk sikit, adduct sikit. So dia akan reduce the diameter of the fetal shoulder. And then lastly ada juga symphysiotomy. Symphysiotomy ni maksudnya dia potong mak punya symphysis pubis tu kan impacted, the anterior shoulder is impacted at the symphysis pubis, so dia potong kat symphysis pubis tu so to allow the passage of the anterior shoulder. But this one is very high mortality and morbidity, so it is obsolete dah, tak guna dah. Okay, lastly yang ni abdominal surgery and hysterotomy. So tadilah yang I've mentioned before, macam Zavanelli tu dia memang buat cesarean section, betul? Cesarean section dia tolak masuk balik, lepas tu dia cut and then cut it off and then cesarean lah. So maksudnya baby is delivered through cesarean section. Tapi kalau abdominal surgery and hysterotomy tu dia akan cut the uterus, open up the uterus, and then they manipulate the fetus through the incision, and then the extraction of the head is still through the vagina. So itulah bezanya abdominal surgery and hysterotomy ni. Tapi this one not much clinical importance sebab dia memang tak buat lah. Hysterotomy and abdominal surgery and hysterotomy is never been done currently. Okay, now regarding the complications, so there are a few complications that you should know lah once we talk about shoulder dystocia. For maternal, postpartum hemorrhage because of the overdistension of the uterus, and then symphysis separations yang I cakap tadi, symphysis will be separated, but this is very rare. Then perineal tear. Okay, so talking about perineal tear, this is also a prerequisite for you lah. When I talk about perineal tear, I'm actually masukkan third degree and fourth degree perineal tear lah. So third degree and fourth degree is the one that will cause incontinence, fecal incontinence, because the tear tu, dia tear perineum tu sampai kepada dia punya internal sphincters yang anal internal sphincters. So the patient will ended up with fecal incontinency. Third degree and fourth degree tear ni cuma boleh repair dekat OT saja. So first degree, second degree can be repaired in the labor room. Third degree, fourth degree tak boleh. Okay, so itu a complication of perineal tear, third degree and fourth degree, complication of shoulder dystocia, which is third degree and fourth degree perineal tear. Okay, and then extended episiotomy tear boleh juga, and lastly is uterine rupture, especially in mother who have a VBAC. VBAC is vaginal birth after cesarean. Maksudnya previously dia dah ada cesarean section, currently dia try to do a vaginal birth. So because of the overdistension of the uterus due to shoulder dystocia, so yang the healing spot of the previous cesarean section tu rupture. So the uterus rupture, mother end up with very debilitating condition lah. And then next is for fetal. Fetal, they can have a brachial plexus palsy, clavicle fractures as I mentioned tadi, fetal hypoxia, okay, ended up with cerebral palsy, humeral fractures, and also lastly is fetal death. Okay, so itu je untuk complications, right? So this is just documentations. When you have a shoulder dystocia case, you need to, as an attending physician, you need to defend yourself by documenting the medical legal form yang ni lah. So ni form untuk medical legal, right? Okay, so now settle about shoulder dystocia. Sebelum kita masuk the next subtopic, boleh tak kalau kita open floor question kalau pasal shoulder dystocia ni? Ada apa-apa nak tanya?
Hello, Assalamualaikum. Ada satu soalan nak tanya. in real life practice and dekat hospital, how common all this maneuver buat ataupun memang orang opt for directly pergi ke OT terus?
Okay, good question. Kalau in our clinical setting, they will not opt for OT first. Dia akan buat maneuver ni. Maneuver ni, they will try for one maneuver, they try for about 30 seconds. Ataupun at least 2 times. Dia try 2 kali make robot tak jadi. Dia try 2 kali make robot scrub pressure tak jadi. Dia akan move on to the entering maneuver. Dia try about 60 seconds tak jadi. So dia akan move to the next. And then once complete one cycle, dia akan try lagi sekali. Kalau still tak boleh, dia akan consult dengan attending physician, dengan obstetrician. Kalau obstetrician datang and tengok memang tak boleh ni, tak ada harapan. So baru dia akan push to OT lah. Tapi sepanjang saya pernah tengok 2 kali show dari sosial, dua-dua Mac Robert dah settle. Maksudnya dia buat Mac Robert dengan suprapubic pressure, the fetus is dislodged. So nak kata common masuk OT untuk buat Zavanelli ataupun symphysiotomy, cledotomy tu semua tak common lah. The answer is not common. Normally they will respond by doing the previous maneuvers dulu, yang entering maneuver and also the Mac Robert maneuver. Okay, I hope that answers your question. Okay tak? Clear tak?
So dia berapa, dia punya tempoh tu berapa lama?
Tempoh tu dia tak ada definite tempoh macam 1 minute buat Mac Robert. Tak ada. Dia macam it depends on the clinical judgment of the doctor tu. So dia rasa macam dia dah buat 2 kali still tak discharge, dia buat entry maneuver still tak discharge, and then baru dia akan consult dengan punya obstetrician, and then they will decide together nak proceed ke OT. So dia tak ada tempoh. So the answer is dia tak ada tempoh. Tak ada definite tempoh 1 minit, 2 minit, tak ada.
Okay, clear. Thank you.
Okay, ada lagi ke yang pasal shoulder sosial yang tak clear? Sekejap saya nak ambil charger. Okay, kita sambung dengan postpartum hemorrhage. Alright, now another subtopic of obstetric emergency, which is postpartum hemorrhage. Alright, so kalau tak nampak beritahu tak nampak ke start ke apa beritahu. Right, so these are the outline of my presentation. Okay, first of all, tengok ni dulu. So by definition, what is postpartum hemorrhage? Postpartum hemorrhage is blood loss of more than 500 mils through vaginal delivery, or blood loss more than 1000 mils through abdominal delivery, or any blood loss that is sufficient enough to cause hemodynamic instability. So talking about hemodynamic instability, we have the clinical symptoms and signs that are correlate with hemodynamic instability. So kalau symptoms tu maksudnya macam excessive thirst, profusely sweating, dizziness, things that are correlate with shock juga lah, sama lah symptoms dia. And kalau signs tu, patient will be tachycardic, hypotensive, tachypneic. So that is clinical signs of hemodynamic instability. So this one I refers from RCOG, Grim Talk Guideline 52. So dia ada mention sini lah, dia punya definition. Currently the definitions dia a bit different daripada buku. So kalau you nak tengok yang latest, you boleh tengok daripada guideline yang ni lah, RCOG Management of Postpartum Hemorrhage, Green Top Guideline number 52. Okay, now classification, they can classify PPH into number 1, timeline. Number 2, volume. So the first one is timeline lah, primary dengan secondary PPH. So primary occurs within 24 hours after delivery. Secondary from 24 hours to 6 weeks post delivery. Tapi from RCOG that I've shown you, they revise the definition from 24 hours to 12 weeks. Cuma mind you that certain lecturers they are very updated, certain lecturers they are not updated. So kalau lecturers yang tak updated tu, dia still guna yang 24 hours to 6 weeks lah. Tapi macam Dr. Azhar, everything Dr. Azhar, whatever come out from his mouth is RCOG, nice guideline. So if you talk about 24 hours to 12 weeks, it would be better. The same like macam saya masuk sikit lah, saya nak share yang clinical experience lah. The same like pre-eclampsia. So pre-eclampsia dulu kita ada minor pre-eclampsia tak. So placenta previa. So dulu placenta previa ni kita ada type 1 placenta previa, type 2, type 3, type 4 placenta previa. So later on kita develop minor placenta previa, major placenta previa. So Prof. Hamizah dengan Prof. Zalina still pakai lagi lah benda tu kan. Tapi sebenarnya benda tu dah obsolete lah. Kalau you mention pasal minor, major dengan Dr. Azhar tu, dia macam he will not be impressed, tapi dia akan judge you yang you tak updated lah. So sekarang ni placenta previa dia ada low lying placenta, dia divide into low lying placenta ataupun previa. So dua je, low lying placenta ataupun previa. 2 cm from the os is previa, 2 cm above the os is considered as low lying placenta. So my point is, kalau you kena tahu lecturer je lah. So susah sikit macam Mishkat tak masuk clinical lagi, so you tak banyak teaching clinical. So a bit tough lah kalau you SM clinical teaching tapi tak kena lecturer. Tapi along the way, try to be observant lah, tengok waktu teaching online ni macam mana dia orang punya style. Macam yang fifth year Invictus, insyaAllah kan korang dah tahulah macam mana style lecturer semua. Okay, so kita balik ke topik ni. For postpartum hemorrhage, dia divide juga yang current guideline, they divide into minor and major. So minor 500 to 1000 mil, major is more than 1000. Major pula dia ada moderate and severe. So 1000 to 2000 is moderate postpartum hemorrhage, severe is more than 2000. Okay, now the causes can be divided into 40. So bila doktor tanya causes of PPH, 40, tone, trauma, tissue dengan thrombin. Okay, so the most common is uterine atony lah, tone. Uterine atony is the most common, about 70%. Okay, kenapa? So you need to understand, the prerequisite is you need to understand how the uterus works. So the uterus works by contracting and then relaxing, and then contracting again and then relaxing. So that's why kalau patient yang in labor, you tengok dia punya pathogram tu kan. So you kata kalau pathogram masa latent phase of labor, normally dia 2 in 10. Maksudnya 2 contraction dalam 10 minit. Kalau dia dah in active phase of labor, kadang-kadang dia 4 in 10. Bukan kadang-kadang, dia memang akan 4 in 10. So 4 in 10 maksudnya dia ada 4 contraction within 10 minutes. So contraction tu maybe happen for 50 seconds ataupun 1 minute and then dia subside down and then dia happen again, subside down. So kenapa dia macam tu? Kenapa dia contract? Kenapa dia kena relax? Sebab if they are contracting berterusan, dia contracting, so there will be inadequate blood flow to the uterus. Okay, so this is the concept lah, sebab ramai yang tak faham kenapa uterine atony can cause PPH. Okay, so uterine atony ni dia maksudnya the uterus is not contracting at all. So when the uterus is not contracting after delivery, so the blood will be gushing out. So dia tak ada anything that can compress the blood vessels. The tone of the muscles tu tak ada. So the blood will be gushing out. So that's why uterine atony can cause PPH. Okay. So settle about this. Nanti you baca yang statement yang bawah ni lah. Yang bawah ni I letak ni. Okay, trauma of course lah, trauma, cervical injury, vaginal injury, everything can cause PPH. Then tissue retained product of conception. Let's say retained POC ni placenta lah contohnya. Tissue ni, bila kita cakap tissue, kita refer pada placenta. So kalau placenta tertinggal, dia akan menyebabkan contraction, tone of contraction tu not adequate. Dia akan kacau tone of contraction tu juga, so akan menyebabkan PPH. And then lastly is thrombin. Thrombin ni maksudnya systemic disease that are related to pre-existing or acquired coagulopathy. Now, risk factors, saya tak nak baca semua ni. So risk factors, I'll just highlight a few. Number one is over-distended uterus. So over-distended uterus, they tend to be related with polyhydramnios, multiple gestation, everything that can cause large for gestational age. They can cause overdistension of the uterus and eventually cause uterine atony. And then uterine muscle exhaustion, contohnya macam precipitated labor. Precipitated labor ni maksudnya labor dia terlampau cepat. Dalam 3 jam dia dah settle daripada 1 cm kepada 10 cm dan dah settle beranak terus, and second stage semua dah settle. So precipitated labor pun menyebabkan abnormalities of the uterine contraction. Okay, lepas tu of course infection definitely cause abnormalities. And then anatomic distortion, for example patient with fibroid uterus, anything yang tak sepatutnya exist dalam uterus tapi dia exist, macam fibroid ataupun previa ataupun abruptio, so these things will affect the uterine contraction. Okay, then bladder distension. Bladder distension ni is very important lah. The first thing when patient ada PPH ataupun bila kalau macam siapa yang pernah masuk labor room tu, lepas patient labor, you kena massage the uterus tau. Massage. Eventually lepas 2 minit macam tu, you akan rasa uterus tu akan turun pada 20 weeks tau. 20 weeks ni dekat the levels of umbilicus. So initially dia level 37 minggu ataupun kalau patient term 38 minggu. So bila you massage pada dia ni, dia akan turun pada 20 minggu dekat levels of umbilicus. So you tahulah this one is corresponding. So maksudnya betul ni macam dalam buku. Okay, kadang-kadang you massage tapi you tengok kenapa tak turun-turun ni, kenapa tak turun ni. So waktu tu you kena tengok dia punya bladder full tak. Kalau bladder dia full, you kena catheterize. So you catheterize, once you catheterize, normally you massage again and then the uterus will be contracting. So nak katanya pointnya kat sini adalah bladder distension can cause abnormalities of the uterine contraction. Itu je saya nak kata. Okay, drug induced hypotonia. So if you see here, Mexaf, nifedipine, salbutamol. So ni semua adalah tocolytic agent. So excessive tocolytic agents, they can also prevent enough contractions of the uterine muscle. Okay, lastly is idiopathic lah. Okay, this one genital trauma memang apa tu orang kata ni common sense lah. You dah sebab dah ada trauma kan, of course bleeding. Then retained POC, as I mentioned before, it can be either retained membrane, retained cotyledon ataupun accreta, increta, apocrita. Okay, so untuk sesiapa yang tak tahu accreta, increta, apocrita ni ni you punya learning outcome lah. So, tapi basic lah sikit So, kalau patient yang ada previous history of surgery towards the uterus, tak kisahlah surgery apapun, yang paling senang cesarean lah, previous cesarean section. So dekat side of surgery tu, side of incision tu, dia akan ada fibrous tissue build up apa semua kan. So the healing process is there. So in the next subsequent pregnancy, kadang-kadang your placenta will be impacted dekat side where the healing process occur untuk previous pregnancy tu. So that placenta tu will be morbidly adherent towards that side to the level that it will invade your uterus. So placenta tu eventually nanti dia akan jadi tak boleh nak di remove. Okay, yang paling teruk adalah pekrita lah. Pekrita tu dia invade adjacent organ. Maksudnya dia invade the endometrium, dia invade the myometrium. Eventually dia keluar daripada myometrium tu, dia pergi kepada colon, dia pergi kepada bladder, dia invade pula the bladder. So this one is very life threatening condition lah for pekrita. So tu basically the idea lah. Kenapa morbidly adherent placenta ni can cause PPH. Okay, now abnormalities of coagulation, this one is medical. Apa-apa yang boleh masalah dengan darah. Okay, now the clinical presentations. Okay, clinical presentations is the same as the clinical presentations of shock. So the symptoms is anxiety, thirst, nausea, cold, pain, dizziness. The signs rising fundus, Ni yang saya cakap tadi, rising fundus tu maksudnya the fundus is not contracting after the delivery. It should be contracted. It should be. Okay. And then pallor, reduce urine output, tachypnea, tachycardia. So these are the same clinical signs and symptoms of shock. Okay. So estimation of blood loss. When we talk about estimation of blood loss, if you think using your common sense kan, kalau kita fikir sama-sama, macam mana you want to quantify? You cannot quantify. If you quantify, your quantification will be imprecise. So that's why there will be an more accurate measurement with less than 15% reduction error. So kita guna apa? Kita guna weighing grapes, pads and swabs. So ni adalah pictograph. So pictograph ni digunakanlah dalam labor room. So kita alas ataupun kalau patient bleeding inside kan, so kita akan masukkan kadang doktor masukkan vaginal pack yang hujung ni. Vaginal pack, lepas tu dia tengok berapa banyak darah yang ada. So nanti akan ada satu nurses yang akan jot down berapa estimated darah yang patient hilangkan. Itulah. Okay, ni pictograph ni Dr. Yakin saya tanya ni, Dr. Yakin yang registrar. Okay, so ni kena tahu. So lastly, in terms of diagnosis tu you tengoklah yang based on the estimation tu kan, 500 mils, 1000 mils, and clinical signs and symptoms. So that's the way you to diagnose. Okay, investigation at that moment because of obstetric emergency. So because emergency, you need to intervene first. You need to manage first. Okay, so kita start dengan management dulu. Nanti kita akan go through sikit investigation. Management, first of all is prevention ataupun early recognition. Sama juga tadi, general measures. You need to know the risk factors lah. And then you need to early diagnose PPH. Okay. Then general measures. So semua ni maksudnya you buat sekali. Okay. And then ni prevention. So prevention ni, early recognition ni for antenatal, you tengok risk assessment at booking dia. Patient yang ada iron deficiency anemia, so you kena optimize the pre-delivery HB. Lepas tu you kena tengok patient ada blood disorder ke tak, sebab one of the factor tadi thrombin kan, so you tengok dia punya record ada blood disorder ke tak. Lepas tu you tengok previous cesarean section. Ni kenapa? Sebab you nak tengok yang tadi risk of acrita, percrita and incrita. Lepas tu you nak tengok ni elective patient can be opt for elective cesarean ke tak. So let's say kalau kita kata macam this patient ada high risk untuk dapat PPH later, so kita akan ubah kita punya plan daripada SVD kepada elective cesarean ataupun kita buat induction of labour. Okay, macam itulah maksudnya. This one is the early management lah. So intrapartum ni sama je lah. Episiotomy, lepas tu you manage that stage, active management of that stage of labour, watch out for risk for macam chorioamnionitis. Okay, lepas tu prepare for emergency cesarean section. So this is part of the management. Then postpartum, once patient dah diagnose ada PPH, you kena monitor dalam HDU lah. HDU ni high dependency unit. Labor room, biasanya tak monitor kat labor room, kita monitor dekat HDU. Lepas tu you kena bagi active infusion of oxytocin. This one I talk later. Okay, now early diagnosis of PPH based on the estimated blood loss ataupun based on the hemodynamic compromise. Alright. Okay, let's say doktor tanya kan, what is your definitive management? Tadi tu general measures, maksudnya you divide general measures tu antenatal, apa yang you nak buat, you nak optimize hemoglobin, you nak tengok patient ada risk factors macam risk factors for blood punya masalah apa semua kan. Tapi dia tanya sekarang, what is your definitive management if patient end up with PPH? Okay, so your definitive management is you need to call for help, activate red alert. Okay, red alert ni dia maksudnya red alert ni it involve a multidisciplinary team. Kalau disocial tu dia tak red alert lah. Dia macam that one is obstetric emergency but it's not red alert. Tapi pre-eclampsia dengan ni apa? PPH is red alert. Maksudnya once you activate red alert, orang-orang daripada transfusion akan datang, orang-orang daripada NS datang, IM datang. So dia akan ada shared care, multidisciplinary approach once you activate red alert. Then first of all, you need to resuscitate the airway, breathing, and circulation. So normally we answer like this. So first, I would like to institute a resuscitative measure. I would like to secure the airway and breathing by putting patient on high flow oxygen, and then I will insert a 2 large bore cannula at the antecubital fossa, and then at the same time I take the investigation. This one baru you masukkan investigation, and at the same time I take the investigation for full blood count to see the level of hemoglobin, group cross match to see because the patient later on would probably need transfusion, so I send GSM straight away, and also I would like to send for coagulation profile to see the PT and APTT, and then I will start to give IV crystalloid run fast. Macam tu lah basically the way you answer in your clinical setting. Okay, nanti lagi apa lagi doktor akan lagi apa lagi you nak buat kan. So next in line you kena insert CBD lah. CBD sebab input output monitoring kan. So I would like to insert CBD to see strict monitoring of the input and output charting. Okay, and then I would like to continuously monitor the vital signs, and not to forget I would like to refer the case to my senior obstetricians and also the pediatrician. Okay, so macam tu lah basically the way you answer. So saya tak baca pun semua ni, saya just tulis je semalam kan. Okay, and then lastly, after that, after I have do the definitive management for the life-threatening conditions, I would like to see what is the source of the bleeding. So next instance your answer would be you would like to see the next source kan, the next the source of bleeding. So first you tanya diri you, placenta out and complete tak? So maksudnya placenta tu you kena tengok sama ada retain placenta ke tak. Kalau ada retain placenta, so the next signs of management is you need to do MRP. MRP is manual removal of placenta. Okay, maksudnya you akan masukkan tangan you, tarik placenta tu. So this one is another topic. Okay, and then you give a prophylactic oxytocin infusion. Yang ni, prophylactic oxytocin infusion ni I will talk later in uterine anatomy nanti. So kalau you dah buat MRP, fail juga. Contoh macam patient perkrita kan. Kalau you buat MRP, confirm tak dapat. Confirm tak keluar habis. So you kena consider surgical intervention juga. Sama ada you open up ataupun you buat curettage. Itulah. So this one for retain placenta, senang management dia is MRP. MRP kalau perkrita, different line management. Okay, itu je. Lepas tu kalau placenta dia dah complete, so maksudnya another cause, another treaty, which is you tanya uterus is contracted ke tak. Okay, let's say uterus is not contracted, so uterine atony. So for uterine atony we have two levels of management, medical management and surgical management. So for medical management, for year 5 saya cakap saya year 5 you need to for end of block lah ni ceritanya, for end of block you need to memorize the dose. Dr. Famida expect you to memorize the dose. So you need to give IM symptometrin, tapi the way you answer like this lah. So for uterine atony, first of all, I would like to see the cardiac status of the patient. If the patient have no risk factors for cardiac disease, so I institute an intramuscular symptometrin or IV ergometrin, stat dose 0.5 mg, and then I would like to infuse IV syntocinon in 40 unit in 1 pint saline over 4 to 6 hours. If it is still atonic, then I would like to give intramuscular hemabate 250 micrograms state dose to be repeated every 15 minutes, up to 2 times, and maximum is 8 times. So you need to remember the dose for year 5. Year 3 saya tak sure lah kena ke tak kan. Tapi this is the way. So for medical management you have 3 levels symptometrin, and then infusion of syntocinon atau oxytocin, and then hemabate. Hemabate ni adalah carbopros. Carbopros ni PGF2 alpha. Okay, so itu 3 lah. So if let's say fail, so I try a bimanual compression. So bimanual compression, the way you just imagine so doktor tu dia akan buat penumbuk macam ni. Dia akan masukkan tangan dia daripada through the vagina up until the fundus, and then another hand with pressing on top of the fundus daripada luar, daripada perut lah. Pressing. So this is known as bimanual compression. So the idea is that when you are compressing, you are limiting the blood from gushing out. So itu adalah bimanual compression. And then the next insight is balloon tamponade. Balloon tamponade ni dia macam satu wayar, hujung dia ada balloon tau. balloon you masukkan dalam uterus tu, and then you masukkan selain dekat satu dia ada tempat dia lah, masukkan selain, and then the balloon tu daripada deflate dia akan inflate, and then compressing on top of the uterus. So dia bila dia compress tu sama juga dia nak akan limit the blood flow. Okay, so daripada medical management, 3 drugs tadi, you pergi kepada bimanual compression, and then you pergi kepada Beckley balloon tamponade, Beckley balloon. Then let's say if it still fail, then only you do a surgical intervention. Ni, saya ada gambar punya. Beckley balloon ni macam ni lah, Beckley balloon. So you masukkan, dia mula-mula dia deflate. So bila you masukkan selain, dia akan inflate. Jadi macam gambar yang kedua ni. Okay. So next in line is surgical intervention. This one, B-Lynch suture. So saya pun tak tahu lah surgical intervention ni, saya tak pernah tengok. Tapi the theoretical part is that the first line is B-Lynch compression suture, yang ni. The second in line is ligation of the uterine artery. Ligation of the uterine artery or ligation of the internal iliac artery. And then you can also, with the help of the interventional radiologist, you can do uterine artery embolization. So the idea is you want to cut off the blood supply towards the uterus. So uterus akan mati, so dia tak akan bleeding lagi. So that's the role of embolization. And then lastly, last but not least, is hysterectomy. So hysterectomy maksudnya you completely buang the uterus. So tu ada 4 lah surgical intervention. Yang pertama, first line is B-Lynch suture, and then you try artery ligation, and then you try artery embolization, and lastly hysterectomy. Okay. So ini gambar sikit. Okay, lastly kita tengok jenis tract trauma. So trauma tu logik je, bila ada trauma you repair. Maksudnya kalau ada extended laceration you repair, kalau ada episiotomy cut yang still bleeding you repair sampai tak ada bleeding. So that's the management for genital tract trauma. Okay, lastly kalau coagulopathy. So coagulopathy, this one is a shared care decision. So with the hematologist, with the transfusion medicine specialist. So this one saya tak touch sangat lah. So this one is a different topic. So basically kalau coagulopathy, you need to see what is the components that yang bermasalah. Clotting factor ke, platelet ke yang bermasalah. So that will affect your management. Kalau platelet, you can bagi platelet lah. Kalau factor yang deficient, you bagi fresh frozen FFP, fresh frozen plasma. So it depends. So we don't have any specific say on this matter. It depends on the result of the FBC dengan coagulation profile tu. Okay. So kalau still bleeding, let's say you have ambil semua ni, you dah try untuk cater semua benda ni, still bleeding lagi. So you need to think at the back of your mind about uterine rupture, uterine inversion. This one is another topic of obstetric emergency. Operal hematoma and non-genital causes macam amniotic fluid embolism pun obstetric emergency juga, and liver rupture, etc. Okay, so kalau this one interim care ni maksudnya apa yang you kena buat lah waktu sementara nak patient is still not stable. So you do aortic compression, you put the patient lie flat, lateral, maintain facial oxygen, and consider MTP activation. MTP ni pun saya tak touch lah. MTP is very different topic. Kalau nak buat memang sejam lagi lah topiknya. Okay. So the principle is that for one mil of blood loss, you need to replace with 3 mil of crystalloid. So that let's say patient ada 500 mils blood loss kan. So at least you kena bagi 3 pint of normal saline lah. 3 pint tu maksudnya 1,500 normal saline. Okay. Kalau you nak bagi colloid, gelafandin kan. Colloid yang kita bagi biasa gelafandin. Kalau you nak bagi gelafandin, maybe you perlukan 1.5 pint, 750 mil. Okay, ni I've talked about this. Okay, MTP ni nanti bacalah. Okay, lastly is the therapeutic aim of blood transfusion. So once you transfuse the patient, you need to have the aim. So the aim for HB, it should be more than 8 gram per deciliter. For platelet count, more than 75. PT 1.5 times mean control. So nanti ni ada pengiraan dia. Ni fibrinogen ni biasanya tak ada pun result ni. So kita tengok biasanya we are very basic kan, serta kerajaan ni macam tak ada duit sangat kan. So kita buat HB dengan platelet count lah. From the FBC we see the HB and the platelet count. So if it meets these two, then we say it's okay lah. Okay. Now kita tengok sikit macam soalan pour exam Altia ni. Okay. So dia punya kepala soalan ni tak lengkap tau. So kita baca lah. 41 years old lady, gravida 5 para 2 plus 2. So go to antenatal clinic in view of positive urine test. Dia tak cakap pun urine test apa yang positif kan. Miss period for 3 months, unsure of date, period is irregular, GDM. So ni dia punya GDM. GDM is dia punya apa orang kata key point dia. Have GDM in previous pregnancy, all pregnancy is through vaginal delivery. Okay, so trigger 1 ni saya tak nak jawab. Saya fokus terus kepada trigger 2. So nampak ni, she delivered a baby boy weight 3.7 kg. So 3.7 kg ni besar ni kan. So dia mesti ada lagi dia punya statement ni, tapi budak ni tak hafal. So she lost 1,500 mils during delivery. Okay, so ni question yang dia tanya second stage of labor management. So that's why I told you that the management is very important. You need to memorize all the drugs dengan dia punya surgical intervention tu kan. Then prevention of PPH. Prevention of PPH as I mentioned tadi, yang general measures tadi. Okay. And then causes of PPH pun 40 yang you jawab 40. Thrombin, stone, trauma. Apa satu tadi? Thrombin, stone, trauma. Saya satu tu kan. Tengok balik. Principal management at this stage. So sama juga. Dia minta management juga. So everything ni nombor soalan 4, 5, 6, 7 ni it carries 30 marks lah. So banyak kan. So that's why the key point is very important for you to know PPH inside out lah. Okay. So saya rasa tu je. Minta maaf kalau ada apa-apa yang tak meet your expectation. Sebab saya pun dah tak ingat sangat sebenarnya PPH ni, sebab tak pernah jumpa. Kalau short dystocia tu memang kita dah pernah jumpa 2 kali, kita akan ingat at the back of our mind tu, kita memang ingat sangat-sangat dia punya situation tu. So PPH ni saya tak pernah jumpa. So kalau ada apa-apa nak tanya boleh tanya. Kalau ada apa-apa nak betulkan boleh betulkan. So that's all good.
Thank you for the speaker for a very informative sharing. Next, I would like to open the floor for any question or clarification regarding with the topic. You can open your mic or write in the chat box to ask the question. So if there is no question,